endodontics. Everybody knows what endodontics is. Endo, inside, dontics, tooth, so inside the tooth, working inside the tooth, so root canals. And this is just one of the specialties that we talk about, that we have specialists that take care of, you know, all the difficult cases, or anything that we don't, not necessarily all the difficult cases, but anything that we don't want to do, that we'll send to them. Alright, so more commonly referred to as a root canal, or RCT, is the dental specialty which focuses on the diagnosis and treatment of the tooth pulp and periapical, so around the apex tissue. Okay, so what are the indications for the treatment of a root canal? When is a root canal or a root canal needed? One, the patient comes in and there's gross inflammation, so there's swelling either outside of the tooth or even inside the tooth, which is the pulp. So pulpitis is one diagnosis that we give. That means there's inflammation inside the tooth. The nerve is inflamed for whatever reason. The tooth is dead, necrotic. Okay, the tooth may have gotten a trauma when you were playing baseball or softball, got hit, or fell off your bike, and over time the nerve dies and it'll get an abscess. It'll just eat away on the bone. So in order to save the tooth, you've got to do a root canal. Take the dead nerve out and fill it with something. The tooth has to be restorable following endodontic treatment. I mean, there's no sense in you having a tooth that's broken or gross decay where there's a lot of missing tooth structure or a fracture that you're not going to be able to save. So that wouldn't be an indication to do a root canal. And sometimes patients will come in and they've lost a crown that's been leaking, and by the time you clean out all the decay, you end up with tooth structure that's right at the gum line or down below the bone level. You could do a root canal and try to put posts and build it up, and you can probably put something there. Again, the patient's going to spend, you know, probably close to $2,500, $3,000 to save a tooth that is probably going to fail. You know, it may be good for a year, maybe less. You can't guarantee it. You get some patients that say, do whatever, save it. And as long as they know that it may not hold, may not last, you can do it. But usually we end up, nowadays, especially with implants, our first recommendation is take it out, put an implant. Because you're going to spend about the same amount. It's going to take a little bit longer, but you're going to spend about the same amount, and you're going to get something that's more predictable with a better prognosis. Okay, if it's a cavity, carious, mechanical, or traumatic exposure to the dental pulp. So if we're cleaning the cavity, cleaning, and click, we clean the last little bit and we see blood coming out of the middle of the tooth. Well, that's what we call a mechanical exposure to the pulp. Or if traumatic means that, you know, they fell off their bike and broke the tooth in half, and you've got an exposure. And carious, again, just by removing decay. If you go into the pulp on an adult tooth, you've got to do a root canal. Okay? Well, I'll take that back. If the root isn't completely formed on a young patient, you may not do a root canal just yet at that point, but it will eventually need a root canal. Okay, so those were indications that you need a root canal. When don't you do a root canal? Again, we talked about excessive tooth that breaks down to the gum line and you can't save it, or gross decay that you don't have enough tooth structure. Okay, so due to decay or trauma, if you have a tooth that's out going to your cheek that's really not functional, okay, why are you going to put $2,500, $3,000 in a tooth that really, you know, you're not using? Again, you explain that to the patient, and prefer, you know, put that money on something else, or If you need a crown on another tooth, don't spend it on a tooth that you're really not using. If there's a tooth that has excessive bone loss, okay, if there's a tooth that's periodontally involved, that long-term prognosis is not good, you know, you may not opt to do a root canal. If you do, the insurance is not going to pay if the patient has insurance, and the patient needs to know that it's all out of pocket. For the root canal, usually insurance will pay 80%, crowns they'll pay 50%. So if you're paying $1,000 for a root canal, you know, the insurance is going to pay $800. So, but if you send them a picture and there's, you know, more than half of the bone is lost, or the tooth has some gum problems, they're going to deny it, and the patient needs to know that the $1,000 is out of pocket, not $200. So that sometimes determines whether the patient does it or not, because some patients aren't going to pay, the insurance isn't going to pay. All right, so again, we talked about when root canal is needed. So you get a patient that comes in and you start to ask them, well, what's going on with your tooth? What are the symptoms that you're having? And these symptoms here are what you're paying attention to know whether the tooth needs a root canal. And we'll ask them, when does it hurt? How long has it been hurting for? Does it last? Is it long, short, sharp, dull, throbbing, constant? Anyway, spontaneous. If you're watching TV and the tooth just, bam, out of the blue starts hurting, that's not a good sign. Or if it hurts, you know, for a little bit, then it dies, and then it hurts again, that's not good. It may hurt a little bit and then it goes away, but if it just wakes you up in the middle of the night or watching TV, it hurts and it lasts, that's not good. If it's severe, okay, on a scale of 1 to 10, you know, it's 1 or 2, may not be needing a root canal. If they say, oh, it's an 8 or a 9, or it's above a 10, it's worse than having a baby, you get a lot. You know, man, I could have my baby, but this tooth hurts more than having a baby. That, you know, that's severe pain. Lingering pain is another one, okay? We ask them, when you drink something hot or cold, it hurts, how long does it go, or how long does it stay, how long does it last? Or does it just, you drink something cold and it goes away in, you know, 5 seconds or so? That's a little bit, you're not sure if it needs a root canal yet. If you feel it or push on it, on the gum or on the tooth, palpate it and it hurts, that's an indication something's going on. If you tap on it, or they say it hurts when you bite, that's an indication that something's going on. If there's just swelling, like, you know, those pictures that I showed you of those patients with a swollen cheek or something, that's an indication something's going on. Then you take a look at the x-ray and there's an radiolucency, or a shadow at the end of the root. Okay, that's an indication. Okay, so these you need to know, and you need to know, I think, 3 or 4 for your exam. Okay, so spontaneous pain, severe pain, lingering pain, any of those pains. Okay. Palpation, percussion. You guys know what palpation means. If you feel when the doctor, you know, palpates your abdomen, just pushing. Percussion means you're tapping on it. Okay. So, and then swelling or a shadow at the end of the root. Okay, so you've got 3 pains: spontaneous, severe, or lingering. Again, you get lingering means it just lasts longer than a few seconds. And palpate, percuss, mastication is chew, and then swelling. And know a few of those. Okay, when we're doing an exam, okay, this is our exam. Palpate, light pressure applied to the suspected offending tooth and surrounding tissues. This is how we determine if the patient's not sure which tooth, and we start playing a detective inside their mouth. We palpate on the outside, on the inside, push on the tooth. Thermal sensitivity. Okay, we've got a spray that's called Endo-Ice. And so we put that spray on a little cotton pellet, and it's cold. You put it on the tooth, And normal response when you put a cold something on the tooth, it'll feel cold. As soon as you take the cold away, it goes away, you know, in a second or two. That's a normal response. Or sometimes you'll put the cold and they don't really get a response. That could still be normal, especially on an older patient, because again, on an older patient, the nerve is not much nerve left there. You put it on a child and they'll feel it. So we'll put hot or cold. If for hot, we've got some hot wax we can put on a tooth. And again, see if it lasts. Transillumination means we shine a light. Sometimes you can't see anything and there may be a fracture. So we'll shine either a curing light or some of those little pen lights on the side of the tooth. And you can sometimes, you can see this. Okay, you shine it through, it's like looking at an x-ray, especially on front teeth. Sometimes you'll see a big shadow, or you'll see a fracture, or see something. These are healthy teeth, but this is what transillumination is. You shine light, and then you use your mirror to see. Or you can see, sorry, that. You put your curing light or something, and you can see that that tooth is fractured. You can see how the light doesn't go through the fracture because it reflects the light a different way. If this wasn't broken, the tooth would be white all the way around. The light will just travel. You can see that fracture there, that fracture there. Clinically, you may not detect it. You transilluminate and you'll see some of those fractures and take a picture of it and show the patient. It's like, I think this is what's causing it. Okay, selective anesthesia. Okay, sometimes, especially on top, you know, we're tapping and different teeth bother them. You tap in the back and that one hurts. Tap next one, that one hurts, that one hurts. And they all hurt. And you're not sure. So sometimes we'll numb up the back tooth. So we'll give a anesthesia on the back teeth, see if it goes away. If it went away, then you've narrowed it down to either tooth number 1, 2, or maybe 3. If it didn't go away, then you're coming more forward. So you selectively numb up teeth to try to, sometimes you'll get patients that say it hurts on the bottom, and it could be a top tooth that's hurting, because you'll get referred pain. So you try to numb up the top and see, the patient says it hurts on the bottom, well, I think it's probably the top one. I know it hurts on the bottom, but let me see. You numb up the top, pain goes away. So sometimes, again, you're plain detected. If you get a tooth that's loose, mobility, if you have a tooth that's got an infection, that infection is pushing the tooth up, it's putting pressure underneath it, and so that tooth will be kind of lifted out of the socket, out of where it goes, and it's going to move. And if it's got a big infection, it's really going to move. And that's why when your patient bites on it, they say, when I bite it hurts, because that tooth is up, so it's not in the same bite. Okay, so these are the things that we use to test. An EPT, electric poke tester. So if they tell you to go get an EPT, it's not a pregnancy exam. Okay, we'll show you. It's an electric poke tester. It's just a little battery device. You put a sensor on the tooth, and it starts to send a voltage through the tooth. If that tooth is alive, eventually, and we can try it on some of you guys if you want to know what it feels like. It doesn't hurt, but eventually you do feel a zing on the tooth. It tells you the nerve is alive. If you have a root canal or a tooth is dead, if the tooth is necrotic, that little counter goes from 0 to 80. Healthy tooth, you're going to get it somewhere around between 20 and 35, 40. That's on a healthy tooth. Anything higher than that, it starts to, you know, either be an older patient, or if it goes to 80, that nerve is dead. Okay, so you'll tell the patient that tooth is dead, you need a root canal.
Are we highlighting all of these, or was it just that one?
These you need to know.
So I seen it had the.
Yeah, you need, trying to think what the question is on the exam for this. I think it tells you. I think you need to know 3 of these. I don't know why I didn't flip the little tree there, but
Is it fill in the blank?
I'll check. What's that?
Is it fill in the blank?
I think, yeah. And I'll double check when we're done. I think it is. What's the question? I think it's worded, yeah. I think it is filtered like put three of these. 3 techniques that we use to identify a tooth that needs a root canal. So any of those. There's one there, selective anesthesia, so that one, I'll have to go back and look at the exam. Okay, a rubber dam. Anybody has had a rubber dam placed on their mouth? Yeah, so rubber dams are really good. Especially patients that have lots of saliva, or if you're doing a root canal, you want to try to put a rubber dam if there's any question on isolation. It's just the easiest way to go. If I'm doing a composite and I keep the tongue getting in the way, or I'll just put a rubber dam on it, and that does it. Okay, so what does it do? It improves visibility, and you guys will check. You guys will put rubber dams on today on the mannequin, and again, it retracts the gum tissue, it keeps the tongue out of the way, it retracts the cheek, it keeps the saliva and everything underneath. Okay, so again, decreases moisture. It prevents anything from, if you're doing a root canal, you're using Clorox to rinse the tooth, okay, which is caustic and patients don't like it. So you don't want to, if there's any possibility of them tasting it or getting it on their tongue or possibly swallowing, you want to have a rubber dam. Okay, it prevents inhalation or swallowing of small instruments. Again, you've got a burr, you've got hand files, and you'll see the files in a bit. You don't want to have them swallow any of those, so you put a rubber dam. This is what it looks like. Okay, and they're different colors. I think the ones we have here are either green or gray. Some have this division for pediatric teeth, for adult teeth. Okay, so if you're doing tooth number 30, okay, you're gonna make a hole right here. Just punch here. You've got a hole puncher, and you punch a hole. If you're doing tooth 24, you punch a hole right here. Okay, these are the clamps. This is an anterior clamp, and then you've got, you know, a small molar, premolar, and then molar clamps. And we'll talk about those clamps when we've got them over there. And some have wings, some have no wings, and you use them depending on what you need. In the mouth, you've got saliva, so that kind of acts as a lubricant to allow you to floss through and isolate the teeth. On the mannequin, I think we may have, I think we use shaving cream. I think we've got some. If not, you can wet it a little bit and it goes. It's kind of what it looks like in the mouth. Okay, it's got this is the frame. It's got an opening up on top. Okay, this is connected on the bottom. Make sure it's not upside down, because then it goes over the nose. You need to allow them to breathe. But again, they've got a clamp on the back and a clamp in the front here, and then they've isolated those 3 or 4 teeth there in the middle. Again, you're not going to swallow anything with that. Okay, this is a different dam. Okay, this one doesn't have a frame. It's got a frame inside of it. Okay, so you don't have a metal frame. And you just punch the teeth through, and then you floss through to keep them in place. Okay, questions on the rubber dam? Know what, and I think that's fill in the blank. Know what it's good for, what it does.
There's a lot of fill in the blanks.
It's good for you.
It's bad for me.
All right, types of endodontic treatment. Vital. What does vital mean?
Alive.
That the nerve is alive. So vital pulp capping. Okay, so we're going to cover a live pulp. So methods used to stimulate dentin formation. What do we put to stimulate dentin formation? You guys remember?
Former crest.
No, that's to stop bleeding. When you get a really deep preparation and you put what on the deepest part of the preparation? Starts with a C. A. L. C. I. U. N. Calcium hydroxide. Calcium hydroxide is what you put. Okay, so on a vital pulp, if you're almost into the nerve, it's called an indirect pulp cap. When there is a chance of nerve exposure, a small amount of carious tissue is left. Calcium hydroxide is placed on the top of the area closest to the nerve, and then a permanent restoration or temporary restoration is placed. Okay, so you dig, 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 you almost into the nerve. You sometimes will leave just a little bit of the decay right above it, just so you don't expose, and you put calcium hydroxide to stimulate secondary dentin, and you tell the patient, this is what happened, I put some medicine, it may work, it may hurt as soon as the numbing wears off. You may need a root canal. Okay? What's the difference between indirect and direct? You're cleaning, and click, and you get a little bead of blood coming through, just in a little pinhole. So when nerve exposure occurs during an operative procedure, calcium hydroxide is placed over the exposure and a temporary restoration is placed. The tooth is then monitored. If it remains asymptomatic, the permanent restoration is placed. Whether you place permanent or temporary, that's up to the dentist. You just make sure that you tell the patient, we exposed into the nerve, we weren't closed, it actually bled. So that's a direct pulp cap. Indirect means that we were close. Okay, know the difference. Okay, so that there, you start cleaning, and you see this is what we call blushing. You clean the decay and you're almost, if you guys can see, it looks red. And there may be an exposure there, I don't know, I don't see blood, I just see blushing, but they may have rinsed it out. Okay, so you tell the patient you may need a root canal, but you know the filling itself isn't that big. We'll put some medicine there, fill it, and see what happens. Okay, you put either calcium hydroxide, or if you're going to put a composite, we use limelight. Okay, so that's probably limelight there. And you tell the patient, and then you fill it. Put a composite. Okay, so that was that. I'm not sure if that's direct or indirect, because I don't know if they exposed. If it bled, it was a direct. If it didn't bleed, then it was indirect. Okay, pulpotomy we've gone over. Removal of coronal pulp, so just what's in the chamber on the crown of the tooth, is a pulpotomy. Leaving the pulp in the canals. Okay, on a baby tooth, pulp within the chamber is removed. You put hemostatic agents, which is form of creosol or hemodent, and you leave the nerve in the roots. Make sure it stops bleeding, and then you put your final restoration. On an adult tooth, when you do this, okay, and we'll cover this in a bit. It's like I said, it's on an adult tooth on a young child where you have an exposure, but the root isn't completely formed. So you can try a pulpotomy where you do the same thing, take the nerve out of the crown of the tooth, and leave what's underneath, hoping that that nerve, that root will continue to form and close, and then you're going to do a root canal later. Okay, so again, pulpotomy, here's decay into the pulp. You go in there, remove them with a burr, you leave the nerve inside the canals because they're vital, and then you fill it with whatever. Okay, we've seen this before, that's kind of what it looks like when you're looking down on the tooth. And it's not bleeding anymore. You can still see blood, but it's not oozing out. If it's oozing out, then you got to make sure that you stop the bleeding, and then you fill it. Again, this is what it looks like on the X-rays, and you've got permanent teeth down at the bottom, so that's why you want to hold on to them. Okay, what you do on an adult tooth that you do on a pulpotomy on an adult tooth, this is what you're trying to do, apexogenesis. You're trying to allow the apex to close. Okay, so the process of performing a pulpotomy on an adult tooth with the goal of apex formation. So if you get an 8 or 9 year old that fell and broke a tooth on the bike, you may just take do a pulpotomy on the coronal part, put some medicine, and hopefully that root is going to continue. Because if it doesn't close, they've got to go and do the likelihood of you saving that tooth is not good if the root canal, because that root, you won't be able to seal the root, and they'll either have to go in there and do surgery to try to seal, or you lose the tooth. So you try this apexogenesis by doing a pulpotomy, put medicine, and hopefully the root forms. And then you do the root canal once the root completely closes. Okay, pulpectomy. That's when you take the nerve out of the whole tooth. Okay, so on an adult tooth, that's a root canal. On a baby tooth, it's a pulpectomy, and you spin the zinc oxide eugenol into the canal. On an adult tooth, we're doing a root canal and filling it with some plastic material that we'll talk about. Okay, debridement just means the removal. To debride means to remove stuff. So removal of necrotic or diseased pulp tissue. Okay, if there's a root canal that fails, or you have again that patient, that child that the root canal didn't completely close, then you're doing surgery, and this is what's done: apicoectomy. Okay, where the tip of the root is clipped off, and they fill from underneath the tooth, so they don't access through the top. So they enter into the side of the tooth where it's infected. They curette that diseased tissue, and then they fill. They put a filling, retrograde, so from the back. It's a restoration placed on the root from the bottom. Okay, and it looks like this. So here you have a tooth that's got a root canal. There's an abscess here. This tooth has an amalgam core. Okay, so it's going to be real difficult for the endodontist to drill through the gold crown, go through the metal filling, and hope to find those canals without perforating or weakening the tooth more. So what they do is they cut. There's already bone loss there, and if they just make a little incision on the gum, and if there's a little bit of bone, they just break a little window, just click through it, and you'll fall into the space. Okay, this abscess. And so they go in there, they cut the end of the root, and then they fill with a little more solid material. They used to put amalgam. Now they use remember what it's called. It's like a cement, like a composite cement material. It's got a name, but I don't remember what it is. Questions on apicoectomy? So apexogenesis, you guys know what that is? Apexogenesis. That's on the test.
The process of performing a pulpotomy on an adult tooth with the goal of an apex formation.
Yeah, so you're trying to get the pulp or the root to form, the apex of the root to close, to form, finish forming. Okay, so some of the instruments that we use. Okay, before we used to do root canals, just we'll open it and just by hand, file by hand. We still do some, but now we're using more rotary instruments. Okay, so we use a handpiece, and the difference between a root canal handpiece and the regular handpiece is that the handpieces that we use, you can set the speed, because you can't have the speed varying, because you're going to catch that file and snap that file. Okay, so the endo hand pieces that we use are electric, so you set the speed, and actually they're preset from the factory depending on the types of files that you use. So we use a rotary instrument, put the files in there and just go in and out and enlarge the canal. This is one of the ones we have. This is the older one that we have. Okay, again, you just set the speeds depending on what you're using. So this is the hand piece from here to here. You just pull it off, put it back on, and this is what's sterilized. This part. This is just wiped down, the cord, and this is just wiped down. Patients like the handpiece because it doesn't make any noise. It's just quiet. It's just like a little buzzing sound. It doesn't have the air noise. Okay, a brooch. I think we've talked about this and showed it. Is a small barbed instrument designed to navigate the root canals and remove pulpal tissue. So that's a barbed brooch. Okay, it's got little spikes, little hooks. You put it, once you expose into the canal, you put it in there and you pull out the nerve, whether it be that or a little sliver of nerve, whatever's left. Okay, so the brooch you use to remove pulp tissue. Then you've got reamers, used to clean and enlarge pulp canals. Okay, it's just a file, basically. Okay, endodontic files are available in multiple sizes. They're used to remove pulpal tissue and enlarge and shape the root canal. Okay, so the files, we're going in there and just basically making room, because the canal is small and narrow and dark. You can't fill it. You take the nerve out, you've got to open it up so that you can put a filling material in there. If not, you can't. Okay, stoppers. Rubber stoppers or rubber stops placed next to the handle of the endodontic instrument to mark instrument length after obtaining the length of the pulp canal. So to do a root canal, again, everything is inside the tooth. We don't just fill. We've got to clean and disinfect and sterilize it, widen and lengthen to a certain length. You know, all teeth aren't the same length. So you take x-rays, you measure with a meter, and then you set your files. We'll show you. You set your stops. These are your stops. Right here. Here's your handle. Here's the file. Okay, here's a 20, 25, 30, 35, 40 file. These stops, you slide them up and down after you measure. The doctor will measure one canal and say the canal is 18 millimeters. So you move the stopper and you use a little ruler and you set it at 18 millimeters, and that's what you're going to hand to the doctor. If you set it at 19 millimeters and the tooth is 18, guess what's going to happen? Well, you're going to be out the end of the root. So it's important that you know how to measure, because if your hand, especially if the doctor is trusting you to measure, and we'll show you different rulers, some are better than others and easier to use, but you need to make sure that you put it what they say, because if it's plus or minus, you're either going to be short or you're going to be long. You can be short, but you don't want to be long. You can be long with the first file, but if you keep getting long, and you're going out the end of the root, guess what's happening? If this is the apex, and you put a file, you know, a 15 file, and then you go through, and then you put a 20 file, and you put a 25 file, and you're going through, this is what's happening to the apex. I mean, you're just opening the bottom of the tooth. So the bigger you open it, the tougher it is to plug. And that's why some root canals will fail sometimes, because you didn't get a good seal down there. So you don't want to go out the end of the root. Normally we stop about a millimeter before. Again, those are the stops. This is what we use to measure the tooth. Or you can use x-rays, but when these came out, I mean, these are awesome, and they're pretty accurate. This is a little probe. You hook this onto the lip, you put a file here. Okay, you've got, it lights up, you start to go into the tooth, into the canal here. The closer you get, this meter will start to come down, come down. This is where you want to stop, between here and here, about 1 millimeter. If you go out here, it'll just start beeping. It'll go beep, 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 beep. Means that you're out the apex. When you hear that beep, then you pull back a little bit. If you're with an 8 file or a 10 file, it's okay, because there is an opening down there, and that's how you know that you're there. But you don't want to be here right at the apex. You want to be here about 1 millimeter. 1 millimeter from the apex. Because once you put the cement, you're going to get some seal there right at the apex. Again, these are the rulers, and Dr. Cervantes will talk about some of these. You've got these thumb rulers. Again, you put your thumb here. You've got these foam for the doctor to play darts with the needles or with the files. Throw the files in there at you. Just kidding. Again, so that you're not handing a file that's sharp. You know, you'll have that, and they'll put it onto that little ring, okay? And these little sponges are just, you just cut them and replace them. This is, I think, the best type of ruler. You put the stopper on top, and these are pre-measured. These little holes are pre-measured. Okay, so if it's 18, you put the file on 18 and just push it down till it bottoms out, and it's measured. Okay, so you've got 12, 13, 14, 15, all the way to 19, then 20, and all the way to 27. Okay, so you just drop the file in here, and the stopper gets pushed up. So this is a really neat and precise. I think we've got one or two of those. I normally use this, but if the assistant is setting them, it's easier for them to use this. Paper points, it's basically just a paper towel. After we rinse inside the tooth, we go in there to dry. You gotta have a dry canal that's not bleeding, and there's no saliva and no hypochlorite or anything in there. So you use these paper towels, you just put them in the canal. There's different size again, depending on the size of the file that you stopped at. You could have stopped at a 45 or a 50. You're gonna use maybe a 45 if you stopped at a 50, or a 50 if it goes all the way down to the length. And you're always at the same length. These little hashes, this is 18, 19, 20, 21, 22. So those are standardized measurements. Okay, irrigation. We use Clorox. I use Clorox right out of the bottle. Dr. Cervantes dilutes his 50%. Again, just depends on where you went to school and what you want, what you believe in. But real important that when you're irrigating, especially if you're doing a front tooth and you don't have a root canal, your suction has to be right on the tooth. Again, you don't want the patient swallowing that or getting it on their tongue. So you use a surgical curette or a surgical suction tip and put it right there, so that when you irrigate, you're sucking it up right out of the access hole. Okay. The syringes that we use, they're little needles. These are blunt needles. They're not sharp. They have a hole off to the side, so it kind of, when you squirt it out, it creates some circular motion down here, and it brings up loose debris as you're filing. Okay, so again, the irrigation is called the irrigant, and another name for it is sodium hypochlorite. And that's a name that you should know, because if you go to an office and they say, can you get me some, you don't want to say, can you go get me the Clorox? Okay, the patients don't like Clorox. You don't want to say, go get me the Clorox. So the doctor's going to tell you, can you get me the sodium hypochlorite? Okay, and that's chloride, or Clorox. So know another name for it, because you'll go, the what? And they're gonna say, what? You don't know what sodium hypochlorite is? So just learn that. Gutta percha, this is what we use to fill on an adult tooth. What do we use to fill on a baby tooth? You guys remember? When we do a pulpectomy on a baby tooth? IRM or ZOE, zinc oxide eugenol. You're close. It's that, like that. Remember, you could mix that, when we mixed that over here, you could mix it like a paste or a cement. Yes, that stuff. That's what we put in there. On an adult tooth, we put gutta percha, which is a plastic. And you can put a cone like this, or we've got the newer materials that you heat in a little oven, and it turns soft, and you just slide it down into the canal. And along with that material gutta percha, you put a cement basically. And again, you mix it 1-to-1. It's just an endodontic sealer, and there's all kinds of cements or sealers. Obturate means to fill. Okay, we're going to obturate, and the carriers actually for the newer root canals are called obturators, because they have the gutta percha on the it's kind of gutta percha on a stick basically, and you heat it and inserted. So to obturate needs to fill. Okay, we'll go over the steps real quick because we're going to do the lab here in a bit. You put a rubber dam or isolate. Okay, so and this you have there in your book, so that's what it looks like. Okay, the first thing you open into the pulp chamber, find the canals. You access with a high speed, and then you remove the pulp either with a slow speed or with your spoon. Okay, then you start with your files, just going in there with a rotary file into each canal, depending on the measurement that you've got. Okay, use your apex locator. This is what an x-ray would look like. This is what we used to do before the apex locator. You put a file, take an x-ray, and see where you were at. This is what we did in school. Okay, you can see the file coming out the end right here. Okay, so you don't want, even on this x-ray right here, it looks like you're barely out, but you can see how, here's the apex right here. Even though this is the end of the root, usually your apex is a little bit short. And on this, it looks like you're right on, maybe just a little bit long. But you're actually about 1 millimeter long. That's why usually we stop about 1 millimeter short, because the apex is usually 1 millimeter from the apex, or from the real end of the root. So again, here's just a little cartoon. You measure down till it beeps. You rinse it with sodium hypochlorite, which is Clorox. Again, you irrigate. Here's your surgical syringe right on top of the hole. And then you start using your paper points to dry. Again, depending on what size you use. You measure your gutta percha, you mix your sealer. Again, you mix it 1 to 1, and it should be nice and creamy. You put your sealer on the gutta percha, and then you sink the gutta percha in there. Then you've got these spreaders or pluggers, and I'll show you them right now. These are heated. You heat it, and you go in there and melt the gutta percha. Okay, so here's your preliminary file to make sure that your files are inside the roots. This is your pre-op. Okay, and then here are your master cones. You see that your cones are in there. And they should look just like your files. You're pretty close, and then you take your final fill. So normally there's 4 x-rays that we take. We take a preliminary x-ray before, and we take one with the files in. This one, if you want to verify your cones, so files, cones, and then your final fill. Those are the 4 x-rays you take when doing a root canal. Some may only take 2, a before and an after, if they're really confident. Alright. Take a little 5-minute break, water break, stretch break.